Hello and welcome to the Arex LTX product demonstration. Please note that this is a training aid and should not be considered instructions for use. The LTX kit contains all necessary components, is single use, and comes sterile packed for a period of 5 years. Instructions for use are contained in the kit. In addition, there is a surgeon reminder card attached to the outside of the kit. LTX is an abbreviation for Ligamentotaxor, and this is used in the treatment of PIP fractures with the intent of achieving ligamentotaxis. LTX provides adjustable, reproducible, and predictable distraction of the PIP joint, in addition to active and passive mobility. Please note that older injuries may require the release of the volar plate and other collateral ligaments to achieve distraction. The LTX consists of two 1.2 millimeter K-wires. One is placed proximally, the second is placed distally. In addition, there are two blue spacers on each side and two specific coiled springs. The springs are rotated either clockwise or counterclockwise to adjust the amount of distraction necessary. As previously mentioned, all components are contained in the LTX kit. The kit contains 4 blue spacers with 2 different sizes. There are also 4 caps to cap the K-wires. There is a wire drill guide, in addition to 2 springs, a 1.5 millimeter K-wire and 2 1.2 millimeter K-wires, and 2 rubber covers. It is important to note the 2 different types of spacers. You will notice the difference in the shank of the spacer. One is longer, the other has a shorter shank. This is very important in determining which spacer you will use with your patient. For normal finger anatomy, the shorter shank spacer is recommended. For longer anatomy, the longer shank spacer is recommended. The longer spacer can also be used for improved lateral visualization. There are 4 K-wire caps. In this demonstration, we will only be using 2 of these caps. Finally, there is a drill wire guide used in the placement of K-wires. You will notice that there is a primary reference hole, which will be placed over the proximal K-wire, and then a number of target holes, which will be used to guide the distal K-wire drilling. The Manot wire bender, cutter, crimper is highly recommended for this procedure. There are a number of different features on the Manot device which we will cover throughout the course of this video. The Manot will accept any wire up to 1.6 millimeter in diameter. The primary function of the Manot is the bending of a K-wire. You'll notice that there are 2 grooves on the distal portion of the device. One groove is slightly larger than the other groove. And then there are 2 rails on the opposing portion of the device. First, you will load the K-wire into the appropriate groove, and then position the wire in the rail guide on the opposing side of the instrument. Squeezing the handle, you will notice that the K-wire forms a perfect 90-degree bend. Next, you will observe the wire cutting function, which is self-explanatory. We will begin by placing our 1.2 millimeter K-wires both proximally and distally. The first 1.2 millimeter K-wire will be placed transversely through the center of the head of the proximal phalanx. Second K-wire or distal wire will be placed through the head of the middle phalanx. You will notice a reference hole and several target holes on the wire guide. We will begin by placing the reference hole over the proximal K-wire. Next, we will determine the desired location of our second or distal K-wire by aligning with the target holes on the wire guide. Proceed with the placement of the second or distal K-wire. Please note that the use of the wire guide is optional, and some surgeons may prefer to use a freehand technique to place the distal K-wire. Staying with the distal K-wire, we will proceed now with the bending and cutting of the distal K-wire. This will be performed on both sides of the K-wire. The manot may be placed directly against the skin, as a predetermined space will automatically be achieved with the manot function. Please note that it is very important to elevate the hand during the wire bending function as to ensure the manot is below the wire. Next, we will cut both sections of the distal bent K-wire by placing the manot directly on top of the finger. The final step in the distal K-wire, we will roll the K-wire forward or distally. This will ensure the K-wire is in position to accept the spring. As previously mentioned, there are two different size blue spacers. For the purpose of this demonstration, we will be using the shorter spacer in consideration of normal finger anatomy. Place the blue spacer over the proximal K-wire, and again, by elevating the hand, using the manot to perform the wire bending function. You will notice there is excess space after we've bent the K-wire. It is very important that we reduce that space by pushing the K-wire all the way against the blue spacer. Place the second same size blue spacer on the opposing side of the K-wire. Elevate the hand and perform the same wire bending function using the manot. You will notice that there is again spacing between the wire and the blue spacer. We will center now the K-wire, allowing for equal spacing on both sides. Perform the same cutting function on both sides of the proximal K-wire. Again, the manot may be laid directly on top of the finger. Next is the placement of the springs. It is very important to note that one side of the spring is flattened. The flattened side of the spring will be placed over the blue spacer while engaging the distal K-wire, rotating clockwise until the spring has engaged the spacer shank. Placement of the second spring. Again, flat side first. At this point, you will notice there is no distraction of the PIP joint. By rotating the spring, you will begin to achieve distraction. Distraction can be adjusted on both sides by adjusting the spring. After rotating both springs, you will know sufficient distraction is achieved. You will notice there is some excess spring and spacer beyond the distal tip of the finger. This can easily be trimmed with any wire cutter. Make sure you cut several millimeters beyond the tip of the finger to ensure proper positioning of the K-wire bridge in the next step. We will now form a wire bridge using the third K-wire in the kit, a 1.5 millimeter smooth K-wire. Insert the K-wire into the spring down along the spacer until it reaches the base of the spacer. Using the manot and using the proper bending groove for the 1.5 millimeter K-wire, make the 90-degree bend. Align the Minot groove with the second spring and make your second 90-degree bend. Remove the K-wire and then trim the long aspect of the K-wire in line with the originating side of the K-wire. Reinsert the wire bridge into the two springs of the LTX device and ensure proper length. Ensure proper function of the device and then observe the proximal K-wire has no rotation. There are two rubber covers that are included in the LTX kit. These may be used in place of the 1.5 millimeter wire bridge. Most surgeons prefer the wire bridge. Two pieces of medical tape can be wrapped across the bridge and the springs to hold the bridge in place. The final step will be placing the two caps on the proximal K-wires. This will be done by using the crimping function on the Minot device. Notice there are 4 indentations or divots on both opposing sides of the device. Place the divot over the round portion of the cap and squeeze firmly to properly secure the cap. Repeat the same crimping function on the other K-wire post. A third K-wire may be placed above or below the spring to achieve volar or dorsal subluxation. Thank you for your interest in the Arex LTX device and wishing you good clinical outcomes.